Okay, hello everybody. Could I get your attention please? We're ready to go. So, welcome to this afternoon's forum, brought to you in partnership by Family Planning Victoria, the Royal Women's Hospital and Women's Health Victoria. I wish to begin by acknowledging the traditional custodians of the land we are meeting on, the Wurundjeri people of the Kulin Nation, extending our respect to elders past and present. For those of you who don't know me, my name is Candy Broad. I'm a director of Women's Health Victoria, and I facilitated the first forum and I'm facilitating today's forum. As many of you will be aware, today is the second of two forums. The first forum was held in June and it explored the topic from the provider perspective. Today's forum is going to focus on research. Safe access to abortion is good public health practice and plays an important role in supporting women's health, agency and wellbeing. That is the reason abortion was decriminalised in Victoria in 2008, and it is the reason the sector remains engaged with promoting universal access to high quality pregnancy advisory and abortion services across the state. One of the ways universal access is being promoted is through a service capacity review of contraception, pregnancy advice and termination of pregnancy services in Victoria, prepared for Family Planning Victoria, the Royal Women's Hospital and Women's Health Victoria, the sponsors of today's forum, with assistance from DHHS. We look forward to the service capacity review informing and improving access to pregnancy advisory and abortion services for all women, regardless of age, income, location or social circumstances. And now to the topic of today's forum, which has the capacity to significantly improve access. The availability of medical abortion has increased in Victoria in recent years, and given these changes, Women's Health Victoria, Family Planning and the Royal Women's Hospital thought it would be very timely to bring providers, researchers, policymakers and health professionals together to discuss how the increasing availability of medical abortion has impacted access, new and evolving models of care, as well as ongoing challenges. So can I say thank you very much for those of you who have travelled from regional and rural areas to be with us today. You are an essential part of this conversation and we appreciate the extra distance that you have travelled. On behalf of the partner organisations, thank you to our expert panellists on either side of me who have so generously agreed to share their time and insight. We have a great panel, I hope you'll agree, for today's forum, and I look forward to introducing them shortly as we proceed through the forum. I won't do them all at once at the start. But before I commence that, there are a couple of housekeeping reminders. I understand that there are toilets immediately to the left when you leave this room. On the subject of photographs, WHV staff will be taking some discreet photos throughout the event. However, if you would prefer not to be in a photo, please indicate to those same staff. Timing, following the format of the last forum, each of our panellists has been invited to speak for 10 minutes in order to allow for group discussion and Q&A. That means we will need to keep to time as much as possible, so please hold your questions or observations until all of the panellists have had their opportunity to speak. And I will signal to the panellists, I'll hold up my papers and wave them or something if I think you are going over time. I also need to remind the panellists that I understand that the acoustics in here are not brilliant, so you will need to project so that everybody can hear. We'd like to, at the conclusion, warmly invite you to continue conversations and networking following the group panel discussion. So without further delay, let me introduce our first panellists. Kylie Stevens and Dr. Alana Hulme-Chalmers from the Centre of Excellence in Rural Sexual Health, also known as Kirsch. Kylie is the Senior Health Promotion Manager with Kirsch, which is located in the Department of Rural Health at the University of Melbourne at the Wangaratta campus. Kylie's background is in project management, health promotion and education and training. She's worked in rural Victoria for the past 20 years and is committed to working in authentic partnership with local communities and organisations to improve sexual health systems and to tackle inequities. Alana is a research fellow with Kirsch. She has conducted research and evaluation for state government, local government, not-for-profit organisations and universities. Her research interests include rural sexual health service delivery, the potential of intersectoral partnerships in improving rural health, and rural health program evaluation. Kylie and Alana are going to present an overview of the program of work undertaken by Kirsch in the northeast Victorian, Goulburn Valley and Loddon Mallee regions to establish MTOP services and conduct research to evaluate and document the outcomes. And for the benefit of people from Melbourne, these regions represent a large area of Victoria, which I've previously represented in the Victorian Parliament, and I'm very pleased to hear from people who are working in that region. Over to you.
Thank you very much, Candy, and thank you for the organisers for inviting us to come along today. I would also like to acknowledge the traditional custodians of the land in which we meet today and pay my respects to elders both past and present. Okay, we're up. Okay, for those who are unfamiliar, there we go. Those who are unfamiliar with our organisation, the Centre for Excellence in Rural Sexual Health, or CERSH as we're known, we're funded by the Victorian Government to work in rural Victoria. Our focus is on building coordinated and integrated sexual health service systems and health promotion practice, workforce development for rural sexual health and related sectors, and establishing a research agenda that highlights the impact of rural life on sexual health. And it has been mentioned by Candy, the geographical area we cover, which is highlighted in the map there, we think is around a third of Victoria. So in our region, workers report poor access to abortion and few GPs prepared to provide medical termination of pregnancy in general practice. Consequently, CERSH began working across our region in partnership with a range of practitioners and organisations in 2014. And the goal of this work is twofold: to train and resource both public and private practitioners to enable them to provide timely support to rural women experiencing unplanned pregnancy, and to support the establishment of MTOP services in primary healthcare settings that are coordinated, affordable, address structural issues for women, and that are part of a comprehensive sexual and reproductive health response. Our approach is to focus on equity, diversity and fairness, and we use community development theory and practice and a commitment to authentic partnerships. So the program of work undertaken to date includes the following. There was consultation with 55 workers, including GPs, obstetricians and the education, health and youth sectors, to determine need and interest. Strong endorsement to undertake this work was given by the local sector, and support was provided by Metropolitan Services. We conducted locally based training for GPs and practice nurses in 7 locations, and this was to support GPs to establish MTOP services. A total of 107 so far have attended. Our role involved linking key workers with other established services for knowledge exchange and support. The staff at Gateway Health Wodonga in particular have shared their practices and become mentors and leaders. As a result of this training and follow-up meetings, there are at least 14 additional providers of MTOP in our region. And they're in these locations approximately. SERSH also collaborated with the Royal Women's Hospital, Family Planning Victoria and Fertility Control Clinic to facilitate training for our frontline workers in the education, health and youth sectors to increase their knowledge, skills and confidence to support women experiencing unplanned pregnancy. And following a needs analysis to determine the content, training was held in 2 locations with 83 attending. Hopefully that's coming up. In terms of other work, SERSH and local services contributed to Murray PHN Termination of Pregnancy Health Pathways portal. So the online portal enables GPs to access information about local pathways and protocols and also provides details about top providers in their local area. We've commenced discussions with the Aboriginal health sector to explore the most appropriate service models for Aboriginal women in rural locations, and we will commence a clinical network for medical termination of pregnancy practitioners in 2017. Again, this is a partnership between our organisation, Murray PHN, and with the support of Dr Paddy Moore and the Royal Women's Hospital. In addition to clinical support and education, it will provide an avenue to work collaboratively on rural clinical service development. The development of an online training module about establishing MTOP services in rural areas is also in progress, and this will be an additional module to a suite of online training modules recently launched by SERSH. So on this slide I've listed a range of new MTOP service models that have evolved in our region. I'd like to highlight nurse-led models of care in 3 locations have particular advantages and address issues of inequity for abortion provision. And Catherine Orr is going to speak about that in more detail shortly. Some summary points for me before I hand over to Alana. We don't know accurately how many medical terminations have been managed in our rural locations, but we do know that the services in community health settings have all experienced high demand immediately after establishment. Making information public about local services remains a problematic issue. Some avenues for information exchange that have been useful in our region include our sexual health networks, held regularly in 3 locations, and our biennial conference. Additionally, organisations like the Pregnancy Advisory Service here at the Women's now have a database with new rural providers, and they're also able to inform women of any local options. So that's our program of work in summary to date, and I'll hand over to Alana.
Thank you, Kylie. I'm just going to briefly overview the 3 pieces of research that SERSH has been working on in relation to rural MTOP service delivery. You'll see them here. I'll just describe each in detail now. The first one stems from Kylie briefly raised the issue of SERSH, Family Planning Victoria, the Royal Women's and Fertility Control Clinic coming together to deliver training and support to a variety of stakeholders in the rural context. We wanted to evaluate this to see what were the key mechanisms of change that enabled improved and improving service systems to occur. So first of all, the evaluation design was planned in consultation with the Royal Women's and the Fertility Control Clinic. We interviewed 19 stakeholders who were involved in the process. That was either in facilitating some of those training and information sessions, providing the training or experiencing the training and support. We found that the change mechanisms that I've described here were iterative in that one built upon the next in a way that responded to the stakeholder needs, but also importantly to each location's individual rural context, because as we all know, rurality is not homogenous. Every location is different and has different histories and organisations and norms that go in that area. Dr Paddy Moore's presentation at the 2013 SERSH conference was really a catalyst to SERSH becoming involved in the first place in facilitating the work to establish MTOP services in rural Victoria. One of the interesting things we found in the evaluation were that people described the range of barriers that existed for MTOP delivery in rural areas, and these existed at a service provider level, for example the availability of GPs. GPs are very busy in rural areas. At at an organisational level, so for example the time that's needed to establish an MTOP service system is quite detailed, and it's not a short period of time, and it went all the way through to systematic barriers such as a lack of supporting services in a location. For example, there may be no pharmacy to provide the medication or no radiography for ultrasound. However, there were some enablers that were discussed that did exist in the system, predominantly in relation to the commitment to addressing inequity in access to termination services that was really outlined in detail by the people that we interviewed. Stakeholders noted that the facilitation role played by SERSH in organising training and support was effective because of SERSH's knowledge of local rural communities. As Kylie described, we do a lot of our work in partnerships, so we have that, I guess, rural knowledge, and we're based in rural locations ourselves. And this local understanding enabled training and support that was responsive to each location's specific context. The take-home message from the evaluation was clearly that there was no one model in establishing a rural MTOP service system. Rural health professionals value and take up rurally based opportunities that are cognizant of individual contexts, histories and resources. An organisation like SERSH is invaluable in terms of the knowledge exchange and navigating those complex local landscapes because we're in that local contact with the stakeholders regularly. Now, the next two pieces of research I'm going to describe are actually being undertaken at the moment, so we don't have any results to share, but I'll run you through the aims and the methodology that we're going to use. So the second element of the research that we're undertaking at the moment focuses on a better understanding of the operations of a rural MTOP service in line with calls in the literature for documenting success stories of models that minimise unnecessary barriers to women. So in the study that's being led by Associate Professor Jane Tomney, we're going to examine de-identified clinic records of all the patients who've attended the clinic, which is based at Gateway Health, since it commenced in January 2015. We're going to explore the reported reasons that clients attend Gateway Health for abortion services, the demographics and contraception coverage of the patients attending, and aim to identify any avoidable adverse events. This project will also determine the median cost of MTOP to the patient. The results of the audit will inform future strategies designed to improve access to places like Gateway Health for those women who are most likely to require abortion. And the results will also inform future health promotion strategies undertaken by Gateway Health and SERSH, which are aimed at minimising the rates of unwanted pregnancies with a particular focus on marginalised populations. The final piece of research that we're undertaking is looking to improve knowledge around women's experiences of MTOP in rural Victoria, and we'll be doing these through semi-structured interviews with around 10% of the clients that have accessed MTOP services at Gateway Health in the last 12 months. Understanding the client experience provides valuable insight into the service system from the perspective of the service user. It's likely that these service users will include vulnerable groups of women around which there's a lack of evidence regarding their needs in relation to abortion services. Again, this helps to increase the documentation of MTOP in the Australian context. Together, all three pieces of research will provide an evidence base about rural MTOP within a context that's of value to policymakers, funders, service providers and sexual and reproductive health stakeholders. So in conclusion, we believe that the development of rural service systems to support women experiencing unplanned pregnancy and abortion is viable. This work in Victoria demonstrates that rural regions can create accessible, affordable and timely services and contribute to decentralisation of abortion services.
Thank you, Alana and Kylie. Our next panellist is Dr. Catherine Orr from Gateway Health Wodonga. Catherine is the Medical Director at Gateway Health Wodonga. She's a GP in North East Victoria and also, sorry, I've just got some slightly different notes here, as well as Medical Director of Gateway Health Medical Clinic, oversees Gateway Health Multicultural Clinic, Gateway Health HIV Clinic and Gateway Health Clinic 35, which is a nurse-led sexual health clinic for young people. And Catherine has worked in remote and regional Australia, including time as a solo GP in a remote Aboriginal community. For those of you who don't know Gateway Health, it's a not-for-profit community health service that focuses on the provision of primary health and welfare services to people at highest risk of poor health outcomes. Services are delivered by over 200 staff members at sites in Wodonga, Wangaratta and Myrtleford in northeast Victoria, and through outreach services provided across the region and into southern New South Wales. Over to you, Catherine.
So I'm going to talk about the model of care that we provide at Gateway Health and talk, it's a nurse-led model as we described. I'm going to talk about the following topics. Firstly, our model, why it works, the transferability of the model to other settings and how we provide equity of access. So just some numbers for you to begin with. We've done approximately 250 medical terminations of pregnancy since we started in January 2015. We are at capacity. We could do more. We could run a full-time medical termination clinic, but I'm busy doing refugee health and other HIV medicine and other things. The longest distance a patient has travelled is an 800-kilometre round trip. They came from Condobolin. And we approximate that we've spent about 2,000 nurse and doctor hours in our clinic. So this is a bit of a background to how the clinic was set up. So as you know, the TGA listing of mifepristone and misoprostol was the initiating step. SERSH, as they described, came and did a whole lot of education in our region for doctors and nurses and other providers. A working party was established to include a lot of the stakeholders, and the MTOP training was developed and delivered in our region. And then I undertook, so Clinic 35 is our sexual health clinic for young people within Gateway Health, and I undertook the MTOP prescriber training, and away we went. So what is our model? We have a sexual and reproductive clinic which is integrated into community health, and it sits within a regular GP medical clinic that runs off Medicare billings like every other clinic. The nurse position is funded, however, so that makes a big difference to us because the nurse's position is funded. She can spend as much time as she needs with the patient. I just operate like any other GP on Medicare billings, though I'm not a funded doctor. Clinic 35 is free, and you don't need a Medicare card, and we target high risk populations and hard to risk populations. Because we also run a multicultural clinic, we have a large number of refugees and at-risk migrants that come to our clinic for other reasons, and we have a high use of interpreters, phone interpreters for that population. What's good about a nurse-led model? The nurse-led model works really well because the funded nurse position the nurse can spend as much time as the client needs, preparing them and educating them about their options and the process of medical termination. The nurses spend all the time chasing up the results to make sure the patient qualifies for a medical termination and that they're ready to go. Then I come in, oversee the lot, do the script and talk about any sort of contraception or whatever other issues that might come about. So it's a fairly intensive process, medical termination of pregnancy, and it's ideally suited in a nurse-led model. I do think it does fit with a regular GP clinic, however, with some modifications. So this is where the green star, and this is the sort of area that our clinic services for medical termination. The blue stars are other clinics offering medical termination. So I wanted to talk about affordability. I think one of the main reasons why our clinic has been so successful is that essentially there's very little cost to the patient. Many of our patients come to us and say they would actually prefer to have a surgical termination, but they can't afford it. So we have we did a lot of collaboration in the beginning and sourced a bulk billed ultrasound. All our pathology in our region's bulk billed, so there's no cost to patients for that part of it. The 2 appointments with the nurse and the GP we bulk bill, and then the script, depending on whether you're a Closing the Gap or a healthcare card holder, is the only cost for the patient. I think this is the biggest reason why we're so successful. So why does it work? A partnership approach, so we've really benefited from their partnership and the support we have from SERSH, and I have a good relationship with the local obstetricians and gynecologists who are very supportive, and I can ring them when there's a problem and they will back me up, so that is a lot, very reassuring for me, not that we've had a lot of problems. So the model of care, I think the nurse-led model really allows the patient to spend as much time as they need with the nurse before they embark on the termination of pregnancy. And we've only got one pharmacy that's in Albury and Wodonga. He's actually located over the border in Wodonga. But we have a really good relationship with the pharmacists there, and if we have any problems we ring back and forth. So yeah, just talking about, we have a good relationship with the local other stakeholders and service providers that we might need to engage. Our communication strategy, because we're located in a big community health with 200 workers and patients coming and going for all sorts of reasons, we totally fly under any protester's radar. That's why I think medical termination really fits well in a primary healthcare model with a nurse-led clinic, because I mean, we've got the exclusion zone in Victoria. Just over the border, the fertility control clinic, the surgical termination clinic, has a lot of problems with protesters. We don't at all. And we fought quite hard to have our medical termination of pregnancy on our Facebook page, on our website, and we circulate a lot. We circulated in the beginning a lot of information through the local medical providers, so the Medicare local, as it was described back then. Now we'd really like other practices to take on the work because we're just overwhelmed. So why does it work? I've put cost there first. I think it's a really big factor. A lot of people talk about not being access services because of cost. The nurse-led model, it's integrated into our Gateway Health with a wider clinic. We have a really flexible process, and a lot of education went into the front of house. So when patients ring and they talk about wanting medical termination of pregnancy, our staff are really well educated as to how to get them through and get them in, because it's obviously time critical. So that's been really good. I think the advertising has helped. I'm not too bothered about having our name and everything on Facebook pages and things. We really, as I said before, appreciated the support we get from SERSH and Gateway Health, and the fact that we can run a funded nurse position, and I would really advocate for more nurse-led positions, because I think it's what makes the process work. So how is it transferable? I think it is. I think it's transferable into general practice, but because of the lack of remuneration and there's no particular item number for a medical termination of pregnancy, you're relying on just consultation item numbers. So a GP would have to be motivated, but it's very protocol driven. So you can really run through a protocol pretty quickly, and you know it's not complicated, I don't think. But it's also really well suited to a primary healthcare model where you've got nurses in a clinic already. It's easy. We haven't found it difficult at all. It's the process is very straightforward really, and there's not many hiccups, and our adverse outcomes have been as quoted or less than the stated data. So this is my main message. There's no point in us increasing access to medical termination of pregnancy if we make it unaffordable, because I think cost. The last patient I saw last week before I came, we were away at a conference, was a 15-year-old girl who didn't want her parents to know, and who would have no way been able to afford hundreds of dollars for a termination. That's who we're trying to reach, and I think that's why it works. Thank you.
Thank you, Catherine, and thanks to Gateway Health as well. Our next panellist is Professor Angela Tefft. There's Angela. Angela is a public health social scientist and Professor Director of the Judith Lumley Centre for Mother, Infant and Family Health Research at La Trobe University. For 15 years, she's led the Centre's research program on gender-based violence and sexual and reproductive health in Australia, as well as in Timor-Leste. Angela is going to present the results from 2 national studies. Over 2,300 MSI clients and 200 Australian women aged 18 to 35, and the research investigated the proportion of unintended and unwanted pregnancies and their outcomes, the direct and indirect costs of medication versus surgical abortion, as well as what factors are associated with women who present after 9 weeks and are ineligible for a choice, and then discuss the implications of this. Over to you, Angela.
Thank you. Now I'm going to have to turn around, I'm afraid, and look at these. I'd like to acknowledge the traditional owners of the land as well, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past and present. I also want to pay my respects to my colleagues, because this is always a team effort. And also, as I look around the room, I see many women that I have known who helped to fight to get mifepristone into this country. It was really a collective effort, and there are a lot of women in this room who played a role in that, and I want to acknowledge that. And so I think many of us thought this is going to make it easier. Well, now finally we're going to have access and it's going to be cheaper. That was the assumption. So as a researcher, you know, one of the things you think to yourself is, well, actually, is that true? So the studies that we've conducted are, first of all, we did want to get an up-to-date count of how many women are having unintended, unwanted pregnancies and what happens to those. So that's the first study I'm going to talk about. But I just want to ask, are there any journalists in the room? Okay, well, I'm trusting you all because this first study isn't published, and I just want to share a few things with you because I think it's germane to what we're talking about. Okay, other way. Okay, so what we wanted to find out was how many women have unintended pregnancies over 10 years, how many are unwanted and what happens to them, and does the inclusion of medical abortion improve access and reduce the costs, which was many of our assumption. So we did it this way. We did a computer-assisted telephone interview survey of a random sample of women. Actually, you'll see, and this is a quickly put together presentation, I apologise, 18 to 49, so reproductive age, and then a survey of a sample of Murray Stopes clients, over 2,500, well, just under 2,500. So I'm just going to quickly share the results of the CATI, as we call it. So we got a company to do a very professional survey, a random population survey across Australia. So these are Australian data. This was conducted, I think, in 2014, 15, at the end of that. And the first question was, have you ever been pregnant? So of the 2,000 women in that age group, 1,390 had been pregnant. When we asked those 1,390 women, have you had an unintended pregnancy? Roughly a third had. So that's a third, so it's interesting. I'm just pointing that out. And when we asked, did you want to keep it? Of that third who had an unintended one, 26, so roughly a third of them didn't want to keep it, but there was a sizable proportion who were unsure. So what happened to those pregnancies? Well, 53% had the baby. I haven't gone in, we do have the data to look at, well, where were they? Are they more likely to be in the country or the city? We just haven't done that analysis yet. 15% had a miscarriage, that's roughly proportionate, I think, to most women who have miscarriages. 30% had an abortion, and you will notice that probably the unsures turned to, I actually don't want this pregnancy, and were included in that, so that's 30%, and a few were still pregnant. When we look at what were the characteristics associated with having an unintended pregnancy, so the age range is roughly right across. You know, there's a little peak at 25 to 29, but So it's where you'd expect it to be, but it's pretty distributed across the age groups. 41% were using a contraception. I could make a few guesses as to what kind. And when they look down here, you can see absolutely standard Australian use of oral contraceptive pills. And I know that they can go wrong if you miss one or two or whatever. Condoms are notorious. So you'll see the majority, that's what they were using. And that's in Australia. And there you see the life use, 6%. As Carl said, it's too low. I do want to let you know that together with Daniel Matzer at Monash, we're doing a funded study of trying to increase the proportion of LARCs that GPs are, together with Kathy, people in the room. So other characteristics, well, you've just shown you those data, but look, over 50% already had children. So the client survey, which I'm happy to say is about to be published, the aims were to investigate the proportion of eligible women obtaining a medication abortion, what women's preferences and reasons were. I'm not going to talk about all of those for abortion method choices. The direct and the indirect costs. What else did women need to pay for beside the actual abortion itself? Did they need to make sacrifices for it? And what were the factors associated with women who didn't have the choice and turned up later? So, it's probably one of Carl's slides. These were where the clinics were across Australia. So it's a pretty good distribution down the right-hand side, and a far less, it would be lovely, but that's where the population is. And also where it's legal, obviously. So, just to explain the response rate, the way in which we were able to do this was when women were actually going in for the consultation to have a termination, they fill in forms, and they were asked at that point to fill in a further form that we had designed, and so at least a quarter did, or between a quarter and a fifth did. So we're quite happy to have 2,300 women. The age distribution matches Marie Stopes' outcomes, and I think you'll see that a lot of other outcomes are very consistent with the sorts of things that Carl's been talking about. The mean age of the women was 28. What was interesting was there was an overrepresentation of women who identified as Aboriginal and Torres Strait Islander, which was really interesting to me. Roughly the right proportion of women Australian born, so about 25% who were overseas born. The majority were in major cities. Well, that's also got to do, you would think, with the distribution. But there's a woman who'd come from Papua New Guinea. There were very many long distances travelled by rural women. The majority were employed, and just under half were nulliparous, so hadn't got children or pregnancies, but well over a third had had a previous abortion. And I want to emphasise, I think it's really interesting that 96% of women, when you get protesters about abortion saying, it's all these late-term abortions, almost 100% came in the first trimester, which means that women are actually, for the most part, being able to access Marie Stopes, and 84%, which is a good percentage, within the 9 weeks to have a choice. So if we look at what are the characteristics of the different women? Is there any differences in women who choose medical versus women who choose surgical? Well, yes, there are some. There's no difference for those who had private health insurance. Similarly, no difference with healthcare cards between women who choose a medical and women who choose a surgical abortion. There was no difference between marital status between women choosing either. Well, you probably wouldn't expect that. But interestingly, a higher proportion of Aboriginal and Torres Strait Islander women choose a surgical rather than a medical abortion. One thing that I haven't looked again at the stats around country of birth, but I would suspect that 24% who are students, there'd be a highish proportion who have a country of birth other than Australia. We haven't looked at that yet. And again, if you look at education levels, 22% of surgical versus 14% of medical have equal or less than year 10 education, whereas 39% of medical versus 26% of surgical have higher education. So it looks to me as if the women who are choosing to have a medical termination at the current moment have a higher education, and I'll show you why I think that might be. So roughly half had previous children, but you know, over 1 in 10 had 3 or more. It's a good reason, I think, to seek a termination myself, having 3 kids. 1 in 3 had a previous top and 1 in 5 had a miscarriage. But I think this is what we really wanted to find out from an equity point of view. What does it cost? So one of the things I just want to say, and probably many of you know, your Medicare rebate doesn't go up no matter what your abortion cost. So if you're getting in there in under 9 weeks and you have a choice, you'll see what the cost is. And I wanted to put those the other way around, but I had real trouble with this particular slide. So what you see is there really isn't a difference at the end of the day between the Medicare median surgical and medical abortion, but it is $500, and you know, I know for some women that's quite a lot of money. If you don't have a Medicare, so if you happen to be refugee or migrant refugee woman, or you've got a visa that doesn't allow you, you know, you're going to be up for over $1,000. But at least over 80% had a choice, and as Carl said, women eligible for both options in this group, 35% chose the medical, so it's somewhere roughly a third. But while 41% didn't have to forego any payments to be able to afford the termination, 16%, now that's quite a lot, had to forego paying bills. 8% had to forego paying for food, and 6.5% for rent. So what about the women who turn up late and don't get a choice? 16% after 9 weeks were ineligible. So after accounting for age, country of birth, and all these complicated statistical stuff, so holding those together, women at a later gestation were 3 times more likely to have had to travel 4 or more hours, so that's going to be rural and regional. Twice as likely not to know that they had a medical option. There's an issue to do with knowledge. Twice as likely to be Aboriginal or Torres Strait Islander. 1.5 times as likely to have told us that they had financial difficulties trying to get and pay for a termination, and 1.5 times more likely to have a government pension as their main income. And that's when your Medicare rebate doesn't, you know, give you anything more. So it's more expensive for those with less advantages. So the implications, I mean, actually there's some more results here. This is not a good slide. Women, we're just surmising that part of the issue perhaps for medical termination and the issues around choice have to do with having to go back several times, because then you've got childcare, taking a time off out of your working environment. That maybe we don't know why there's a smaller proportion, but we hope that it will go up as it has in every other part of the world. But despite the Medicare subsidy, women still face considerable indirect costs to do with rent, food and other things. Over 1 in 5 expressed concern about it, and a third relied on financial assistance from other people. The potential, though, for Medicare to improve access will remain limited unless we deal with the knowledge, financial and geographical barriers that need to be addressed. So we agree the potential for telemedicine to overcome barriers should be investigated, and we look forward to the results of the Marie Stopes study. And we also strongly endorse the idea of nurse providers having the time and being in the GPs when the GPs don't want to do it. So this article about the costs is going to be published hopefully before the end of the year, so thank you.
Thank you, Angela. And our next panellist is Dr. Joyce Cheng from the Multicultural Centre for Women's Health. Joyce has over 15 years' experience across diverse fields, including medicine, business and the tertiary sector, having worked internationally as a registered practitioner, manager, researcher and educator. Since joining Multicultural Centre for Women's Health in 2013, Joyce has been overseeing health education programs and health promotion projects that address a range of issues and concerns, including ageing population, intergenerational relationships, informal caregiving and working caregiver, problem gambling, misuse of alcohol and drug, and mental health. And I understand the focus of the presentation will be on, as we see the increasing availability of medical abortion, what does this mean for women from COL backgrounds, which Angela alluded to a bit as well. Over to you.
Thank you, Kenny, for the introduction, and thank you to Women's Health Vic and Amy for the invitation. And it's my great pleasure to be here. While the first and the second forum around medical abortion, I was asked to talk more broadly about a range of areas that impact sexual and reproductive health of women from immigrant refugee background. So, for those who don't know us, Multicultural Centre for Women's Health is one of the two statewide women's health service, along with Women's Health Vic, that works at national level and across Victoria to promote the health and well-being of immigrant refugee women through social action, research, advocacy, multilingual education, and capacity building. So with the Public Health and Wellbeing Amendment, formally passed last year, and an increasing availability of medical termination of pregnancy, women in Victoria are supported to access health services that provide abortion free from, harassment and intimidation. But what does this mean to women from immigrant refugee background? And we're asking whether current services are accessible, acceptable, and affordable for women from immigrant and refugee background. I think a few speakers already touched on that. I was planning to answer this question, draw upon findings and data from different sources. But given the time allocation, I probably will, focus more on findings from a partnership project, as well as our own research, which led by Adele and Regina. I have Regina here this evening. So some of you might have come across this report. MCWH has put together a SIH data report in June this year. According to extant literature, there are differences between immigrant refugee women and Australia-born women in terms of accessing, service, accessing information, using of service, contraceptive use, and contraceptive management. But one thing I would like to draw your attention is the first antenatal visit. Australia antenatal guidelines recommend that the first antenatal visit occur within the first 10 weeks of pregnancy. But from this slide, according to Australia Institute of Health and Welfare, women from born overseas who gave birth in Australia in 2013 were found to have attended their first antenatal visit at later gestational stage or age than Australia-born mothers, which might have some implications to termination if women decide to do so. And next, I would like to draw some findings from a partnership project titled Contraceptive Technologies and Reproductive Choice among Immigrant Women. The project was carried out in 2014 and 15 by our research team consisting of researchers from Monash University and the staff member from MCWH, including our bilingual, bicultural health educators, and also family planning in New South Wales, aiming to explore immigrant refugee women's experience of contraceptive technology in Australia. So analysing data collected through interviews with 84 women from different cultural backgrounds and 16 service providers, we found across the board, women from different cultural backgrounds has basic but lack of detail about the sexual and reproductive health. So that health literacy is low. And women from different cultural backgrounds are less likely to use the pill because of the concerns about side effect and also the cost of the pill. They kind of favor condom, and also withdrawal is a method often used for contraception. Like Australia-born women, long-acting reversible contraception is infrequent use by women from different cultural backgrounds, especially young women or women who are yet to have their first child. I think that's probably because of the concern of not being able to fall pregnancy in the future. And other issues such as health professionals' lack of awareness of cultural norm, and also lack of information, especially printed information in their native language, also were raised by some women participants. There are a range of concerns and issues raised by participants in relation to communication with health professionals and the use of health service. Most women prefer to see a female doctor who can speak the language, so that ensure they can have accurate communication with the health professionals. People from some communities would prefer to see a doctor from different ethnic background because of concern about that confidentiality. Some communities are so small, so if you see a doctor, you kind of spread to all whole community. Some participants report that with the time restriction, doctors and nurses tend not to ask or discuss questions or issues related to family planning. They tend to ask the closed-ended question that requires only yes and no answers just because of time restriction. And strong words were used by some participants to describe their experience of using health system. I have some quotes there. And also, this transnational care is a term we use to describe some women we interviewed tend to hold their appointment with obstetrician until their next overseas trip, because for a few reasons. First, they are able to purchase their preferred brand of contraception pill, but at a cheaper cost or cheap price. So back to that cost again, I think. And also because their lack of confidence in accessing or using the health system in Australia. And so when they see the obstetrician in their country, they are able to communicate with them, so they're understood and they understand health providers in their country of origin. I know I might have approaching my time allocation, but I do want to touch, or quite keen to talk about international students, a specific cohort that is vulnerable to discriminatory practice as a result of misinterpretation of their health insurance entitlement and their rights to access service. So according to Australia Government, Australia Trade Commission, in 2015, there were approximately 650,000 international students residing and studying in Australia, made it third largest export sector for Australia economy. I actually heard news today they contribute 20 billions to Australia economy, so it's a quite amazing. Our own research conducted in 2011-12 found high rates of unplanned and unintended pregnancy among international student population. And the risk is heightened during the first 12 months after their arrival in Australia, when students are adjusting life in a new country and without familiar social support. Here I have the OHSCD. So the purchase and maintenance of overseas student health cover is a mandatory student visa condition. And students who do not maintain OSHC are at risk of having their visa, cancelled and being deported. So the minimum requirements and arrangements of OSHC is stipulated in the D. Since July 2011, under the D, insurers has been allowed to set a 12 months waiting period for non-emergency pregnancy-related service. So on those terms, an insurer doesn't have to provide a benefit to those service, or the benefit to the pregnancy-related service to international students and their dependents. So based on our own research, we developed a position paper which our position is clear. We made a few recommendations, but the most important one is the 12 months waiting period for all pregnancy-related treatment, including termination, should be removed from the D. So after our position paper, in January 2015, an international student sexual health network was established, which the network includes 35 members from all over Australia, including MCWH. The networks also provide an opportunity for members to share information in policy, practice, and research. Any investigation to cost of contraception by network members have found that coverage for international students does not mirror the options and costs for Australians. So they actually put together a position statement which made 7 policy recommendations. Once again, the most important one is to remove that 12 months waiting period. But unfortunately, the network found that the new D, effective this year, doesn't include any recommendation by the network. But the good news is, a reply letter from the department states that a consultative group was established under the new governance of the D. So we were reassured that the position statement will be presented in the next consultative group meeting, which is next week. So we hope things will change after that. So I don't know if I have answered that question I proposed, but I think it all comes down to whether women from different cultural backgrounds has access to culturally appropriate information, including the printing information, and also the cost of service and medication. The cost, Catherine, I like that dollar sign. If it's all $0, I think that service will be accessible and affordable and acceptable. And also come down to the communication with health professionals, whether we will organize the interpreting service or using bilingual, bicultural health educators. That probably concludes my presentation. Thank you.
Thank you very much, Joyce. So our next panellist is Associate Professor Louise Keogh. Louise is a health sociologist and Associate Professor in the School of Population and Global Health at the University of Melbourne. She conducts research into lay and expert understandings of risk, health decision making and the use of health technology. Louise's research in cancer prevention and sexual and reproductive health involves collaboration with clinicians, epidemiologists and scientists to better understand the interface between new technology, the users and the healthcare system. In addition, she teaches qualitative research methods and social theory to postgrad students. And the focus of Louise's presentation, I understand Louise will present the results of recent research that aim to describe the access to abortion following its decriminalisation in Victoria in 2008 and the introduction of medical abortion in 2013. The findings of this qualitative study with experts in abortion provision reveals their impressions about the intent and impact of law reform, GP provision of medical abortion and factors that women take into account when choosing between medical and surgical abortion. Thanks, Louise.
Thank you, and this is a very welcome break from marking assignments today. So yes, we did some qualitative research, and the background of the research was that there'd been these changes in abortion, so the law reform and the introduction of medication abortion, and we were particularly focused in Victoria, and we wanted to find out how are these things affecting access and women's experience, but also providers' experience. So our method was that we did qualitative interviews with experts in the provision of abortion. We had a pretty big range of different experts, so some of them were in private clinics, public clinics, hospitals, GPs, we had managers, we had counsellors, we had a whole range of different people. The people we really targeted were those people who really intimately understand abortion services, so that they were the people that we targeted for an in-depth interview. So the first thing we looked at was the impact of law reform. So experts agreed that law reform was positive and was definitely a good thing, but that it hadn't changed practice. And some felt that things had actually stalled post-law reform. So these are two quotes. To be perfectly honest, the law reform has not impacted that much on our practice, and there was almost a bit of a vacuum post that reform around people making a noise or talking about abortion. So we're really interested in how these experts really perceived the law reform. What did they think it was intended to do, but then what had it actually achieved? So this is quite a busy slide, but if we just start at the top, we've broken down what people told us into various categories. So the first category is what was intended, what did law reform intend, and what did it actually achieve? So it did position abortion as a health issue rather than a legal issue. So this was across the board. All of our experts were really grateful that now abortion isn't a legal issue, it's a health issue. And what they talked about was it shifted the power in decision making from doctors back to women. So rather than the doctor sitting there and feeling that they had to make a judgment about whether this woman should be able to access abortion, the discussion with a woman is now about, does the woman want to have an abortion? It's her choice. So they felt that was intended by law reform and that was achieved. They felt that it had really increased the clarity and safety for doctors. So a lot of them were actually quite taken aback by this, that after law reform they suddenly realised that they weren't feeling anxious about providing abortion anymore. So for them as providers, it really increased their sense of safety. Then they talked about the things that maybe they hoped law reform would achieve but had not achieved, and that was increasing access. So some of them said, well, it was never going to increase access, and it didn't, and others said, well, we hope that maybe with the law reform the access would actually increase as well, but it hasn't. Some thought that stigma might be slowly decreased over time, but all of them uniformly felt that there was still a lot of stigma. And then they talked about things that they talked about an unintended negative consequence of law reform, and that was the Section 8 they felt had increased the legitimacy of opting out, and they felt that it had been adopted by whole institutions to be able to say, well, there's this opt-out clause, so we're opting out as an institution, so that it was being used in ways other than intended. So that was a potentially negative thing that hadn't been foreseen. Then there were what they talked about as coincidences. So they couldn't say this was because of law reform, but happened around the same time. One was a good thing, and that was the introduction of medical abortion. So suddenly there was another option for provision. But there was also reduced public provision and reduced access to post-20-week abortion. So there was a strong sense amongst all the providers that, in fact, access had gone down coincidentally with law reform. And then at the bottom is unfinished business. So there was lots of things they talked about that still need to happen in this space. And two key ones are a statewide strategy for abortion provision and sustaining the workforce. So there was a lot of concern about not having new providers. So I guess these were some of these trends I was surprised by. So the public access, since abortion law reform, access to public services has shrunk. It's not getting better, it's shrunk. The post-20-week abortion, I suppose I've seen a narrowing of services. A few years ago, women were able to privately access post-24-week abortions, but they can't anymore, unless I'd say extremely rare and would be for severe fetal abnormality. And then the workforce issue. There's no new providers or anything popped out of the woodwork, nothing whatsoever, and the providers that are there are getting very old. So these are the things, sorry to any providers in the audience. These are the things that they were very concerned about that came out of a discussion about the impact of law reform. So that was one part of the study. So we were very interested in law reform, but we were also interested in this idea of medical abortion and general practice. So all of our experts defined abortion as an essential component of women's healthcare and saw GP provision as a way to increase women's access, especially for those not in big cities, but also to help with the current shortage of providers of surgical abortion. So they saw it as a really good thing. All of them were in total agreement that GP provision of medical abortion is a real positive. The things they talked about GPs needing in order to do this would be partnerships with local health services, a driver or a champion who could really push these services along, peer or mentor support, so being able to talk to someone, what did you do about this, how did you get around that problem, having good primary healthcare nurse support, and shared resources, so not having to recreate everything every time, but being able to share resources. They weren't so positive about a nurse provision model. Some felt that would be okay, others didn't, but they were very confident about a GP model for medical abortion. So then the other thing we talked about, we were interested in how did they think that women choose between the two options. So we didn't talk to women, so this is not based on what women say, this is based on experts who see women all the time. So we figured they were in a pretty good position to talk about how do women choose between the two. So a couple of trends that came out from that was that GPs often found that women didn't know about medical abortion. So if they'd turn up to the clinic, that GP telling them that was an option would be the first that women had heard of it. So there's quite a bit of lack of information out there, and there's also misconception, so that you take the pill and it just magically disappears and things like that. So women weren't very well informed. But then they also talked about women who'd done a lot of internet research and come in knowing exactly what they want to do, and perhaps talk to family and friends about the options. So oh no, have I lost another slide? No. So we sort of summarised what the experts said about how women choose into both pragmatic factors and subjective factors. So the types of things that they felt women were taking into account was the time that it was going to take, so time off work. So sometimes surgical seems like a better option because it's over quickly and they can't afford to take a few days off to stay home and go through the MTOP process. The location of the procedure, just purely pragmatically, if they have to go to a clinic that's identified as a surgical service, some women would not want to do that and would rather go to a service that was a GP and they're not revealing anything about what they're doing. The pragmatic issue of the support required at home for an MTOP would be an issue for some women. If they're on their own at home, that might not be a good option. So there were these kind of pragmatic factors that women would take into account. But then there was also subjective factors, so perceived risk. So women tended to weigh up which one they thought was more risky. Some would feel that surgical would be more risky, and others might feel that medical is more risky. And then there's perceived emotional impact. So the women obviously think about what kind of emotional impact it's going to have on them. The privacy issue, and these are all perceived things, so perceived control. One woman might feel that an MTOP gives them more control, another might feel that surgical gives them more control. But women were really interested in weighing up all of these different factors. And then of course the perceived physical ability to go through one or the other. So they were that was how experts described women's decision making. So caveats and conclusions, as I said, we didn't interview women. So our findings are expert perspectives. And there's a clear opportunity to address reduced access through MTOP services. However, we were really concerned about the need to increase access to public surgical services as well, and not to think that MTOP can replace surgical services. And also, there are women who are going to need abortion later in their pregnancy for whatever reason, and it's pretty worrying that there was a feeling that that wasn't an option in Victoria. The key enablers that experts identified to deal with some of these things would be a statewide strategy for abortion provision, so having an expectation of who's going to provide these services, and also a concrete plan to address workforce shortages. That's all from me.
All right, we've reached the magic hour. In fact, we're just past it. So thank you everyone who came today and participated. That's much appreciated. And on behalf of Family Planning, the Royal Women's Hospital and Women's Health, can I thank all of the panellists for contributing your time, both to be here and for all of the work that you do. So please join me in thanking our panellists. It looks like we've got some small gifts to express our appreciation on behalf of everyone. Okay, thanks everyone.